Me? You don't have to see me, but at least can you hear me? All good, Kathleen? Okay, great. So good afternoon, everybody. It's my pleasure to introduce Ms. Christina Harrington today. Christina is a senior research scientist at Google Research. She earned her bachelor degree in electrical engineering from VirginiaTech in 2009 and her master degree from North Carolina State University in 2013 and a Ph.D. degree from the Georgia Tech or Georgia Institute of Technology in 2017. Christina Harrington is a designer, research scientist, and a storyteller who examines the ways social identities are reflected in technology, design, and how technologies can consider various aspects of identity to build more equitable technology. She combines her background in electrical engineering and industrial design to focus on the areas of universal, accessible, and inclusive design. She is passionate about using design and methods such as design justice and community collectivism to broaden and amplify participation in computing by addressing the barriers impeding our ability to see design as a universal language of communication and knowledge. So without further ado, please join me in welcoming Christina Harrington.
Thank you so much. Can you all hear me? Is the mic working all the way? Listen in the back corner. You? Okay, cool. So thank you all so much. As you mentioned, my name is Christina Harrington. I'm currently a senior research scientist at Google Research. I always like to give a little bit of background about myself, especially when I'm talking to students, just because I come from such an interdisciplinary background. And as he mentioned, I started off as an undergraduate student in electrical engineering, and then migrated my way into industrial design, actually at VirginiaTech, by hopping into a class with some buddies of mine that were mechanical engineering majors who were doing an industrial design minor, and I was just really curious about it. And that path has led me to kind of be this hybrid interaction design, qualitative researcher, who's also very interested in sci-fi and DIY crafting and woodworking and building with my hands. I've studied all things design for over a decade now. And if I had to summarize the work I do in just a few sentences, my research looks at how we consider aspects of people's identity in the technologies that we create and the interaction methodologies that we use to create them, and in the environments that we build that people interact with every day. I try to focus on who is being considered when we conceptualize these tools and systems, and how we consider the needs of certain communities. So as I mentioned, or as was introduced, I came from Virginia Tech. I'm a former Hokie. I then went on to NC State to get my master's in industrial design, and then a PhD in industrial design from Georgia Tech. I wanted to focus more specifically in HCI, or human-computer interaction. So I went on to do a postdoc at Northwestern before jumping into academia for a little bit, running my own research lab at DePaul University and Carnegie Mellon University, and then finding myself in industry now, starting as a visiting research scientist and then moving into a senior research scientist. And all of this while doing very human factors, community-based, human-focused equity research. That I kind of like to define as exploring equity and emerging technologies. And I kind of envision these things these backgrounds overlapping. My degree in electrical engineering, kind of bringing in that intelligent systems component. My degree in industrial design, bringing in a lot of inclusive participatory methods. And then human factors, a lot of the research labs I worked in both as a master's and a PhD student, were very human factors focused. I even hung around some of the human factors labs when I was here at Virginia Tech. This was back when Woodrow Winchester was here. I'm not sure if any of you are familiar with that name, but this was eons ago. And that kind of brings in this health equity and information access component. And so for most of my career, I've looked at the ways that older adults interact with technology, examining everything from the types of use, the impacts of technology on their daily life, experiences with gestures and interfaces. This image on the screen is actually at the Georgia Tech Aware Home in Atlanta, Georgia, where you actually see an older gentleman interacting with the Xbox Connect 360, where we did a research project looking at how the Xbox could support older adults being more physically active in the home by using gesture interfaces to actually be able to move and follow Tai Chi, do different brain exercises by moving their upper and lower extremities, and also how to elicit more behavioral responses. So how can we use designing interfaces to make people more physically active? Can we use things like gamification? This game actually requires a user to kick a ball that will finish a math equation. So if I say what plus 3 equals 7, there's a ball that says 4, there's a ball that says 5. I'm going to kick the ball that says 4. I'm actually being physically active, but I'm doing it through gamification. One of the things that I started to notice in doing this type of research and doing human factors technology research was that some of these tools are oftentimes out of reach for marginalized older adults, either because of things like digital literacy or technology proficiency, or even cultural barriers, where older adults felt like interventions like the Xbox 360 might not fit my lifestyle. So for those of you who may or may not have been to Atlanta, Georgia is kind of a little bit of a melting pot. But if you go to the Buckhead area of Atlanta, you have more of the affluent, higher income, more educated individuals. And so when we would visit senior living facilities there, the older adults tended to be more educated, have more money, and thus tended to have more experience with these types of technologies. Whereas if you go to downtown Atlanta, you find more racial diversity, but lower income, less access to technology, and less technology proficiency. And thus, when we would test these technologies with older adults in downtown Atlanta, we would find them saying things like, this would be great, but I can't afford it. I would never be able to use this. I'd have to learn how to use video games in order to be able to play this, to be physically active. So there's kind of this learning curve that might stop me from using this in my everyday life. And so it kind of brought me to this research area that I've taken on of examining questions specifically in the context of Black and Brown communities, because in many instances, especially when it comes to designing intelligent systems and interventions, Black and Brown older adults, Black and Brown populations are oftentimes left out of how we think about design and the technologies that we design. And all of this draws on the premise that design can be a catalyst for social change at the margins and is well served in the current challenges we face, particularly in areas of health equity. I'll explain health equity just a little bit, just in case there's anyone that's not familiar. And so one of my main research goals, working alongside many of these communities, is to facilitate equity and health information access in everyday technologies. If I had to give you an everyday, like a common example that you might be familiar with, if you remember at the height of the pandemic in 2020, when information started to roll out about the COVID-19 virus, and there was kind of this trail of first, what is the virus? How is it spread? What does it mean? What are the symptoms? And then you started to see things online like, well, can I drink Lysol to get rid of it? Can I drink bleach to get rid of it? Where can I get the vaccine? Where can I get accurate information? All of these are what is considered health information access. So how easily can I go online or talk to someone or find a resource to give me information? And there is a bit of a health information access gap that causes me to look at how can we design more equitable health information. So what is health equity? Health equity is the absence of systemic injustices that create health disparities. So it suggests that all people are able to attain the highest attainable level of health, and it requires that we value all individuals and communities based on what they need to sustain that level of health. In the United States, groups such as those who are closer to the poverty line, as well as Black and Hispanic communities, experience health more differently, oftentimes with poor health status and lower lifespans. So if we're looking at this chart that's provided by the Robert Wood Johnson Foundation, we see how poor ethnic racial groups report higher percentage of poor and fair health status. And so coming out of something like the pandemic, we realized that the health information access gap is something that needs our attention now more than ever. But we also know that because of disproportionate impacts of these chronic diseases and illnesses and what this means for quality of life, unfortunately, the healthcare system in the US tends to fail these communities. And we know that not only is that by design, but design is an approach to circumvent that. So despite the prevalence of health disparities in many Black and Brown communities, these communities are oftentimes not centered or at the forefront of designing health-related technology interventions, and that puts more stress on access to equitable healthcare solutions. When we think about the emergence of e-health and mobile health technology, and how that's begun to push us in a direction of where we propose that everyone can now have access to health information and resources, just by a show of hands, how many of you have a health-related app on your phone? Whether it be the one that comes with the iPhone or something that you've downloaded, or even a MyChart to talk to your doctor or keep up with your doctor's appointments. So in many instances, this culture of pushing innovation and through tech, right, has actually become a contributing factor to health disparities for those who are not able to either access these apps on their phone, or who don't understand enough about how to use technology to keep track of their health via these apps. Considering where we're at currently, human-centered design is become kind of the trend in healthcare tech. And human-centered design says, I'm going to take the person that I'm designing for and put them at the focal point of designing the system around them, instead of designing the system and then trying to make the person fit the system. It situates to make systems usable and useful by focusing on the user, the needs, and their environments, and by applying things like human factors, ergonomics, usability knowledge, and different techniques. Human-centered design draws on cognitive science and industrial psychology that enables practitioners to focus on developing solutions built around the user. And while human-centered design has helped us to better understand various usability variables that increase performance and system output, it is oftentimes less concerned with how technology and systems are experienced by users at the margins. They may have constraints outside of traditional measures of usability. So when we're talking about things like how fast does it go, how efficient is it at doing a particular task, these are typical usability measures. But when we think about cultural barriers to using certain technologies, human-centered design oftentimes does not account for those things. And so as more and more technology emerges to address health and wellness, we're seeing that health tech has started to create its own form of the haves and the have-nots because of who is centered in design research and because of how traditional usability does not consider these things outside of those measures, which leaves those who may be less technically savvy or digital literate behind. There's actually a paper, a really famous paper in the human-computer interaction research field that highlights how traditional methods of human-computer interaction and human-centered design do not focus on issues of race, ethnicity. Oftentimes, they neglect things like system bias, equity and access when we're talking about that health information access, and considering harm in the methods, both of how we design something, how things are rolled out, and how things are used. So from a lot of this anecdotal data, a lot of the work that kind of led up to like acknowledging the faults of human-centered design, I found that there's a need to focus on how we might center marginalized lived experiences in the designs of digital tools for healthy aging, specifically in the context of Black and Brown communities, because as I mentioned, these communities are oftentimes neglected and left out. Excuse me. So even in sectors that promise to focus on the user over the system, we're still not doing enough. So when we think about recent surgence of technology, such as embodied conversational assistants, we're starting to see more and more work in academic research, industry research being focused on embodied conversational agents, such as text-based chatbots with computerized characters and how that might support health information seeking among groups that typically experience barriers to health information. Looking at prior research in this area, chatbots can serve as both a financially cheaper, a more accessible resource for participants from lower socioeconomic backgrounds. And they may benefit in chatbot interactions since many users have familiarity with messaging interfaces or texting. Chatbots have been proven to be effective in increasing conversation time among some marginalized groups, and they have been shown to improve conversational dynamics and present instant information. These systems show promise to improve information seeking and exchange, and are thought to be more understandable than pre-surveys that are often offered at medical visits for at the doctor's office. Sorry. So in some of the research I've been doing in my lab prior to coming to Google Research, we were exploring the feasibility and different conversational approaches to health information seeking among marginalized older adults, considering digital literacy and technology proficiency and the way these impact experiences with consumer health tools. Specifically looking at embodied conversational agents, AI chatbots, conversational technologies that are now in more homes, on more phones. I'm pretty sure I'm talking to the choir here as I've learned that more and more students are integrating things like ChatGPT and Claude just in every aspect of their everyday life. We're actually seeing that across the lifespan in many instances with people playing around with different chat-based tools. And so while the potential for things like voice assistants, voice technologies, and chatbots for older adults to support has been well documented, older adults who are lower income or who have lower digital proficiency or technology proficiency, or who identify with historically excluded racial identities have been left out of many of this design and research considerations that goes into these technologies. More specifically, as research into cultural reception of speech technologies has begun to examine which languages, accents, and dialects are well received, there is a need to explore how this interaction among racially minoritized users of older adults might be better supported. And so there was actually a study that looked at how racially minoritized users experience errors with things like voice technologies. So speech recognition technologies, things that if I speak to it, it speaks back. And showing that in this particular study, there were more errors experienced by Black users when compared to white users doing the exact same tasks with the exact same systems at much higher rates. And so to analyze both the use cases and challenges, as well as more idealized experiences with these technologies, some of the work I've done has been to examine the cultural dissonance in these particular technologies that leave certain communities feeling as though they are not the target audience or even meant to use the systems themselves. And a lot of what we found was that many participants in that study said that being able to use these technologies meant avoiding using informal contractions or informal language or slang, things like African American vernacular English, things like their native tongue from if they were from different countries, and having to speak in ways that they felt sounded more Caucasian. Participants explicitly described this as the need to be able to code switch, changing from one way of speaking that is more culturally comfortable, yet less formally acknowledged. So when we think about the emergence of artificial intelligence as LLMs in health and how right now they are being positioned to make grand revolutionary changes to not only precision medicine and patient communication, but also just the ways people think about searching for health information in their homes or at their fingertips. There arises this question of whether or not these systems can adequately provide opportunity for more groups to have access to health information and health resources. As these systems continue to evolve, we're seeing things like ChatGPT and AI chatbots evolving very rapidly. Users can now modify chatbot avatars. They can modify voice, they can modify tone, cadence, and to reflect their experiences, but also including things like cultural adaptability and interactivity to help create more inclusive and immersive experiences with these systems. One of the ways that scientists in my current lab are thinking about and imagining AI to better speak to the needs of users across the board is through things like anthropomorphism. Anthropomorphism attributes human-like qualities to technology. So if we say, I want to change the tone to be more empathetic, I want this to speak to me in a kinder tone. I want this to appeal more to like emotions of being nicer, being softer, better understanding. We kind of see that this might be an avenue to better speak to the needs of users across the board, and overall creating more realistic experiences. Anthropomorphism and dynamics of human likeness have become intertwined with the evolution of AI. So as more, newer models are rolling out, we're also seeing more features and more focus on human likeness. And this kind of brings up this question of whether or not this should be an avenue that we explore, whether or not this should be the way that we think about increasing health information access for populations. If I feel like a chatbot is more human-like, will I better trust the responses that I'm getting? Will I feel more comfortable asking questions that seem more risky in terms of my health? Will I trust what it's storing in terms of my information? And so this component of inclusivity must be considered as we begin to see more and more AI become pervasive in our homes and in our lives. And how do we build chatbots when thinking about users that often sit at the margins? If we're thinking about racially minoritized older adults, for example, how do we make these systems inclusive for these populations? How do we consider identity and fair and accurate representation in order to build kind of that cultural competence for equitable health information access? One of the studies that we did at Google Research was looking at what Black older adults felt was fair and accurate representation in terms of voice assistants and chatbots, knowing about their identity in order to feel like these things were efficient and usable. What we're seeing on the screen right now is we had a cohort of Black older adults come into our office and do some storyboarding by saying, here's how I would want to interact with a chatbot if I wanted to ask it health related questions or if I wanted to ask it questions. And here are the things that I feel like it should know about me in order to be able to give culturally competent answers, answers that I feel like actually apply to me. Answers that I feel like are about my health and that would be relevant for me feeling like this is useful. We asked participants about their experiences with using chatbots and assistants. We asked them to identify moments of conflict, and when these systems failed to respond. And we wanted to find out what their expectations were of these systems, understanding who they are, and aspects of their culture, and what fairness meant in terms of these types of interactions. What would accuracy mean in terms of these types of interactions? And you can see one of the responses we got was someone saying humanity. It speaks and corresponds in an intelligent conversation, and is senior friendly. So considering things like my age, considering things like the pace at which I need to interact with it, it's not making me feel like I'm dumb. It's not condescending. We heard things like, I wanted to know regional information. I wanted to know information that's local to where I'm from, so that it's not giving me resources that don't actually exist where I am. And so a lot of what we learn serves to help the field of computer science and human-computer interaction move towards designing more equitable technology, and considering technology interactions when systems ignore things like dialects that are not your standard typical dialects. It reinforces societal cultural exclusions. And in this way, the design of these systems further marginalizes these communities that have been traditionally ignored and who assume that these technologies are not intended for them. So kind of to wrap this up, conceptually, I like to think that this work challenges the ways that we think about technology access and information access, and the ways that we need to expand that access. Technology access encompasses so much more than just physical and sensory accessibility. When we think about access to something, we often think about, can I enter? Can I get to it? Can I touch it? Can I feel it? Am I able to interact in the same way that he's able to interact? But what I want to challenge is that equitable, inclusive design actually expands the way we think about this access to also think about social cultural experiences. What is the background of the user that we're designing for? Where is the user coming in terms of their literacy and proficiency in terms of technology? What is the economic viability? I mentioned earlier the affordability of the Xbox 360 and how having that as a health intervention kind of creates this haves and have-nots. So are we designing something that all users can afford, or would we be designing something that would be deployed and never used because the users that we're designing them for can't afford to financially pay for it? What is the cultural relevance and impact of the technology? And then lastly, thinking about things like anti-oppression and fairness in these systems. And I think that that's a really big thing when we're talking about AI being used for health information access. So I want to thank you all so much and leave time for questions, discussions, comments, and anything that you all might have.
Do we have any question?
Thank you for the talk. So after the findings, after talking to the elderly, and you have this design concepts for inclusive, with inclusivity in mind. Let's say I'm a developer. How can or do you have any examples of how I can practically implement some of these new design concepts?
Yeah, I think a lot of what we're seeing right now, even when we did the first study, specifically looking at having older adults ask health-related questions, was looking at the queries themselves, and how queries are tagged, and how queries are understood. Because a huge challenge was there's so much rigidity in if I ask a question in a particular way, I have to ask a question in a particular way for it to even be understood. And so if I'm someone who is struggling to find the language to describe what's going on with me, say if I have a pain, but I don't know the correct terminology, right? Because I didn't study medicine, I just know what's going on with my body. Is that something that's going to be understood enough to give me an answer that is going to help me? Or is it going to be, does it pick up on one or two words and then regurgitate the same responses over and over again, regardless of what I'm actually asking it? So I think looking at how we define queries, and there have been a lot of projects that have come out of that project, because that was done a few years ago. And so there have been projects that have looked at bringing in the dialects of more diverse users to build databases of voices and dialects to be better understood. One of them is called Elevate Black Voices. Happened at was rolled out with Google, and actually Howard University was a part of that project, and that was really huge. That grew out of that.
Thank you. Any other question?
Thank you for the talk. So I want to emphasize that I was always intrigued by the HCI field, and even in this semester, I'm taking a few classes around usability engineering, advanced HCI, just to explore that particular field. And I want to know that, considering your experience, if someone wants to break into this field, what should, as a student, I should focus on, and like what projects can I build or what classes I can take in order to actually get into this field? Do you have any recommendations on it?
Yeah, that's a great question. So just to repeat, you're asking what are ways to kind of break into the HCI field.
Right.
I would say right now, what I'm seeing kind of, I'm newer to it, but being on the industry side, is I don't know if there are graduate courses in user experience research methods. But that is a huge field that's not going to go away. I can't speak to how it's going to change, because I do know that there are AI tools that are now supposedly able to do UXR research, and UXR research is user experience research. But there are supposedly tools now, but I don't think that they'll ever be good as humans, knock on wood. Because one of the biggest, I think, values of human-computer interaction research is our ability to do qualitative, ethnographic, long-standing, or in-depth research with people. And so I think if there are user experience research methods classes, or just research methods classes that at some point in the semester have user experience research methods, so that you can, number one, know what are the latest UXR methods that are being done by practitioners, and number two, give you some type of experience to be able to speak on your portfolio or your resume to having those skill sets, or played around with those skill sets, and then trying to do some type of internship or research assistantship in that area. If there are faculty here that are doing that work, I think that those are still really, really, really valuable ways to get your foot in the door. Yeah.
Just follow up, like in your day-to-day, since it's a world of AI tools and it has helped and even sometimes redundant the work. So what AI tools have you used? Like, are you using for your research, or are you like, or you don't use any kind of AI tools?
I don't use AI tools for my research. I have my own personal philosophy on AI, but I study AI tools, but I don't use them to aid me in studying them, if that makes sense. But I think that there are a lot of folks who might be. I just don't, as of right now. Yeah, I think I'm really interested. I mean, I'm looking at right now implications and receptions of like generative AI, but I'm not using anything in those projects. I'm just looking at those projects and having people test those projects, test those models.
So maybe as an extension to that question, I'm just curious. Can you comment on the state of the art of the generative AI tools in terms of closing the equity gap? Is the gap closer now? If there are two elderly persons from two different racial backgrounds, they give prompt to generative AI, do they have different answers that addresses their background without explicitly mentioning their background? Can you please just elaborate more on the state of the art regarding the equity gap in AI?
I would say that we don't know yet. I think where we are right now, because one of the I don't want to call it a challenge, because I'm trying to like change the lens of how we look at doing research with and on older adults. But generative AI is not as much in the lexicon for a lot of older adults just yet, other than let me play around with just creating an image to throw on Facebook. And so we're currently doing that work, literally in the midst of doing that work, but I don't have any conclusive answers yet.
Yes.
Thank you, Christina. Question, do you have any kind of collaboration or work with a big tech companies like Apple or Amazon?
Do I?
I mean, like a collaboration or work with these companies?
Not currently. I mean, I've been at Apple years ago, but I don't have any current collaborations.
Any other question? Print.
Thank you. Did you say you had a collaboration with Howard University?
So there's I'm not on it, but there was a project that came out of some of the work that was done around looking at the reception of various dialects, different user groups, and building databases of voices, because and this is published research at this point, but one of the things that we found with looking specifically at voice chat is that there is the study that I showed that showed that Black users have higher error rates is because of the models being trained on certain voices. And so if the models are not trained on diverse voices to be able to understand that the way you, where are you from?
I'm from Delaware.
Delaware. Okay, the way you might say a particular thing might be very, very different than the way someone from New Orleans might say that exact same thing. And that's very different from the way that someone from Southern California might say it. And all of that is different from the way someone in India might say it. And so if models weren't trained on the variability within like various dialects, then users from New Orleans and users from Southern California might continue to get errors where someone in Delaware who might have a different tone or pitch or accent in their voice might be better received. But that kind of grew the Elevate Black Voices project that was done between Google and Howard University. Gloria Washington is a faculty at Howard University that worked on that. And I've collaborated with Gloria, but not on that particular project.
I thought it was Dr. Talitha Washington.
Talitha's on the project, but Gloria is one of the probably leaders of the project. Yeah.
Any other question?
Thank you so much for this talk. I really enjoyed it. Kind of leading off of what you just said a little bit earlier about training models, based on dialects. Have there been any additional research or modeling where you've worked with doctors to also train your models for different types of symptoms that you may experience in different ethnic groups?
I think that's an amazing question. I am not aware of it if there has been, but that's not to say that there hasn't. I'm just not knowledgeable of it or involved in it, although I would really love to be. Because oftentimes a lot of the research I do solely focuses on individuals from the patient side. And I do know that doing, especially like a lot of the research I do is consider like community-based research. Doing community-based research with medical professionals is hard because of their schedule and just their availability of doing those types of projects. But I think that would be really cool, and I kind of want to dig into that now. I'm not sure that work has been done.
Thank you so much.
Any other question? Any question in Zoom, Kathleen? All right, I think then we can end early today. So thank you very much. Thank you. It's a great talk. Thank you very much.
Thank you.